Good evening, everybody. Welcome to another lecture of distinction brought to you by BOFAS. I'm Graham Tutor. I have the privilege of introducing tonight Mr. Hari Prem, who will be delivering the lecture this evening on the principles of orthoses, shoe wear and prosthetics. Mr. Prem is a distinguished consultant from the Royal Orthopaedic and Children's Hospitals in Birmingham. His practice involves both adults and paediatrics, and he has a special interest in flat foot condition. Before we start, I'd just like to mention a couple of quick housekeeping issues. The talk will be around 30 to 40 minutes long, after which we will have time for some questions or even a couple of case presentations if time allows. If you do have any questions during the talk, please enter them into the Q&A box, which you should find the icon just at the bottom of your screen. We'll answer as many as we can at the end of the talk, but we will end tonight's session at 9 p.m. Finally, we will post tonight's feedback code into the chat function, again at the bottom of your screen. Your feedback has been fundamental to making these lectures work so well, so please fill out your feedback, and just remember, if you don't, you won't receive your CPD points or your certificate, so please make the effort. I hope that all makes sense. So without further ado, please allow me to present Mr. Hari Prem.
Hello everyone, I'll be presenting the topic of prosthesis, orthoses and shoe wear. The focus will mostly be on orthoses, as is something we do regularly, prescribed insoles. So going on to the main topic, can you hear me well, Tim?
Yes, we can hear you fine.
Okay. So the foot was described by Leonardo da Vinci as a masterpiece of engineering and a work of art. So it's something rare and it's very difficult to recreate with a few pieces of rubber. And so you've got to keep that in mind when prescribing orthoses. So this presentation will cover 4 sections, which is the mechanics of gait in a basic way, movements of the foot, the types and functions of orthoses, the terminologies used commonly, and a few examples, common conditions. First, by definition, it's an externally applied device used to modify or control the structure and function of the musculoskeletal system. So it's not curing it, it's modifying it. It's been around for a while. In the 1800s, Hugo and Thomas said a few pennies worth of leather can make a lot of difference to shoes by adding wedges, bars, and lifts. And he's famous for the Thomas heel, where he added a bit of medial leather on the heel to tilt the heel or crook the heel for flat feet. The same principle continues to this day. Now going to anatomy, why do we have an arch at all? Now it's no different to a leaf spring in a truck, and it is meant to provide cushioning. And the main difference with that in a truck is that we are changing constantly every few seconds from being very stiff to push off during gait, the foot slightly inwards, and then a fraction of a second later is going into pronation to soften the mid stance. And all those forces are acting through tiny joints, hence the difficulty in providing comfort. And you've got to keep in mind about 4 times the body weight goes through the ankle when you're pushing off. And if you're a 100-kilo person, it's that much more. So when the arch collapses, like when a tendon, like the tibialis posterior fails or the ligaments are very lax, it's like driving a car with a collapsed spring, not very comfortable. The other example I use is a multi-link suspension. The foot is a very complex structure which moves into inversion, eversion, the forefoot adducts and abducts. You also go into dorsiflexion and plantar flexion, and it's all meant to accommodate, like an all-terrain vehicle, the forces from the hip which twist the foot, and the ground reaction forces depending on the surface, they exert different kinds of forces in different directions. And so all these have to be taken into account when you prescribe orthosis. And so again, to stress, it doesn't cure the malalignment, it controls it, and it can't make the gait perfect, it can improve it. And going on with the example of cars, think of feet having a cavus deformity as a sports mode suspension. It's stiff. So there you got to use soft material to make the patient feel comfortable. On the other hand, if you had a very flexible flat foot in a young adult or a child, then you can use hard materials. We all talk about the medial arch, but forget the arch under the metatarsal heads. This is the transverse metatarsal arch, and this is really important in terms of forefoot pain. If there is a reversal of the arch, you can see my cursor going here to the area where there is lots of pressure under the second and third, then you have pain. It's meant to be off the ground. Now, the reason why it's always the second and third which is painful is because the fourth and fifth and the first are like springs. They have a lot more movement. They can roll with the punch. And you can check in your own hand. You can move the fourth and fifth lots, but not the second and third. And so they are more vulnerable. Another factor in anatomy you need to consider in foot pain in general is a tight Achilles. The ankle and the metatarsophalangeal joints work together like a double hinge. You can see that when there is a tight Achilles, the foot doesn't go up at the ankle. So there's a lot more pressure and ground reaction forces in the forefoot. And it's the same with the plantar fascia. If it's really tight, there's less give here. So you've got to consider that as well when prescribing orthosis. We'll talk more about it later. Now, how do they work? What are the biomechanics? It's very simple. The orthosis tries to control various movements about the joint, or it tries to control axial and translation forces, literally like padding on some side or the other. The other indirect effect it has is altering the line of the ground reaction force. And I'll be showing you examples about these, so you don't have to really remember that. Now, in what ways can orthosis help? Now, it depends on what you're trying to achieve and the severity of the problem. And if you want to support an unstable joint, like an ankle joint, which is giving way, you give a brace. If you want to immobilize a painful joint, like after a fracture, then you give a boot. Now, the important bit in red refers to when you're trying to correct a deformity and when you're trying to accommodate a deformity. This is really important in insoles because you cannot correct something that is stiff. So a corrective insole can be given only for a flexible foot, and the accommodative insole is given for a stiff foot where you're providing a cushion without actually correcting the malalignment. Hope that makes sense. Another way in which insoles help, which is distributing pressure better away from the trigger points. So in front, you can see the red areas, which are then converted to less pressure areas by a metatarsal bar. Now, this part is important in the middle. Now, by helping the weight go through the middle of the foot, it dissipates the pressures. In other words, if you use force by unit area and you increase the area, the pressures are going to go down. So it's very helpful. And again, here in the heel, you can see the red is changed to yellow, mostly by providing a little soft spot in the heel where there's extra pressure. So you can alter the pressures, you can change alignment. Now, we often use the word posting. What does that mean? So it's literally as it sounds. You post a certain amount of material into certain corners. So here there is a wedge, and you can see the heel is in valgus. Now it can either be corrective or accommodative. Now if it is fixed in valgus, then it's acting like a filler. So it's an accommodative insole. If on the other hand, you want to convert the valgus heel into varus, then you would do this. You would insert the wedge on the opposite side. So it's a flexible deformity. So you correct it with a posting on the medial side. So valgus to varus. Now, you can do the same in the forefoot as well, if there's a fixed supination or a pronation. And an unusual problem you see from time to time is a elevated first metatarsal. So there, the first metatarsal is not taking weight, so it's causing the lesser metatarsals to take weight and hurt. So you bring the ground or the floor to the foot by simply putting a filler so it can take part in the weight bearing. Hope that makes sense. So if this were high, you put something underneath so it takes weight. Now, what are the various types of orthoses? I'll be running through these examples later on. So you can have off-the-shelf insoles or just wedges, like you can buy off Amazon, gel insoles or heel pads. And you then have the next kind, which is custom-made total contact insoles. They make you stand on a little box and a mold is taken, and it's exactly custom-made for that shape, the insole. Later, you adjust that by adding postings, and that makes it more biomechanically functional. Then you have shoes. You can make adjustments to the heels, soles, and upper. And you have commonly two types of splints. You have calipers and AFOs. Now, though it sounds obvious, a clinical assessment is really important. And you've got to look at the shape and then look at the person walking. A lot of deformities are made worse when they get up from the chair and walk with the weight of the body. And a simple test, we all know about it, the heel raise. And it doesn't have just a bearing on surgery. It also has a bearing on the insoles for flat feet. If someone cannot go on a high tiptoe and don't correct, then the insoles are going to be less effective. And again, find out if it's a fixed or a mobile deformity by moving the joints. You got to know the difference in conditions like cerebral palsy between spasm and contracture. Spasm, to a certain extent, you can control, get the foot into a better position with orthosis, but contractures you can't. You've got to look at the condition of the skin. There might be severe edema, skin rashes, ulcers. They won't tolerate orthosis, so that's important. And of course, look at the sensation. If they don't have sensation, then you're going to cause pressure ulcers if the fitting is not good. And always look at the sole of the foot to look where the callosities are and determine whether it's painful. Not all callosities are painful. Look at the shoe. This is obvious. All of our shoes should look something like that. A little bit of wear and tear on the edge, on the outer side, and the front. The outer side edge wears due to the final fraction of a second inversion at heel strike due to tib end, and the heel goes into subtle varus. Whereas in flat foot, you're permanently hyperpronating, so you wear out the insides. In cavus, you wear out the outside because it's excessively loaded. Now, this is just to show how a mold is taken for custom-made insoles, and then you modify it. Now, going on to common conditions, we'll start off with flat feet. You can see the foot on the left being flat. So what is the aim of the insole or orthosis? Now, I've written auto lift talus in red. Now, this is really important. Just correcting the heel valgus brings the talus up. You don't have to push up the talus by normal biomechanical movement as it happens in each one of us every day. The heel is like a rudder. You turn it in and the talus lifts up. This will relieve the medial pain, which is where most people with flat foot have pain, and offload the talonavicular joint. A few severe ones have lateral pain due to impingement. We'll talk more about it, but if you tilt the heel in, that's going to help. And in the earlier stages, you can help restore the windlass mechanism, whereby the big toe goes up and an arch is formed. So if you're out toeing and you've got a valgus foot, your toe goes up in a skewed way, so the windlass mechanism is not effective. Whereas if you restore the heel, the toe goes up straight, restoring windlass. Now, what are the problems and what are the solutions? Quite often, you find a tight calf muscle. So a little heel lift will help relax the gastrosoleus. Needless to say, exercises are important too. Now, what about the next problem, which is the heel in valgus? Now, you've got to determine whether it is flexible or not flexible. If it is flexible, you put a medial posting to correct it, and it'll tilt the heel in. If it is stiff, then you got to make adjustments in the heel of the shoe, and I'll show you in the next few slides. Now, if the flat foot, as we said, is severe, you can't do a tiptoe, single leg tiptoe, then these people shouldn't have rigid corrective ones. It'll hurt their midfoot. So semi-rigid ones, which are like a cushion, mostly accommodative insoles. Now, at the end of it all, if there is a fixed forefoot supination, then you got to fill that as well by getting the first metatarsal to take weight. As you know, in every flat foot, there's a hidden supination. When you get the heel from valgus to neutral, the forefoot supinates, and you got to look into that as well. Examples of various types of insoles given for flat feet. So if you have the typical early stage flexible deformity, all you need to do is get a molded insole and add that medial posting there. Another variety is the UCBL type of insole, University of California, Berkeley Laboratories, and it has a deep heel cup. This is to control the subtalar joint better. It works mostly in children and those with cerebral palsy or other conditions where you can grip it better. Adults don't tolerate it as well. Otherwise, it's the same principle. You have a deeper medial posting. So this is for the fixed deformity. So it's in red. So you give something that's accommodative. So this material is much softer. You're not making any attempts to correct the heel too much, but it is thicker on the medial side, but the material is softer. So the patient tolerates it. So counseling is important. We'll talk about that as well, telling the patient what to expect. I must confess, I've not used this, but it's for completion of information. If you had the occasional patient who can't tolerate insoles, is got only a low activity status, then you can use this inflatable support here for the arch. It also has an ankle support, so obviously useful if you have ankle arthritis and midfoot arthritis and for some reason cannot have surgery or use insoles. Now, overall, it's difficult to inform the patient and say in advance, this is going to work or not work, but there are means of predicting it to an extent, and it's really important, especially in children, so that you know this person is going to go in for surgery or not will, but may. So I use this list, which seems obvious when you think about it, a big painful callosity under the talonavicular joint, so which means it's collapsed completely, not just lowered. Or if you have femoral retroversion, so there's no internal rotation of the hip, a huge amount of forces are put through the medial arch when you're having an out-toeing gait. And knock knees, same thing. Again, genu valgum, severe amount of pressure over the medial arch. You can't expect a 90-kilo person, 6 foot tall, having these features to have full correction with just insoles. So there's something called too many toe signs. It's made up by me. I'll show you an example. It's just an example of severe forefoot abduction or midfoot break in flat feet, which again can't be corrected fully by insoles. If you're unable to do a high tiptoe stance, everyone can do a low tiptoe stance with just the gastrosoleus, and that's a poor prognostic factor. High BMI, we talked about it. Lateral pain, again, is difficult to correct with insoles because it by default indicates a severe form of valgus deformity of the heel. I'll show you examples of what's not correctable. So this is the too many toe signs. You can see a heavy person having severe valgus and the whole forefoot is broken in the middle. And you better off providing accommodative insoles or semi-rigid insoles in them. Again, an example of the severe midfoot break here. And these people do better eventually with surgery. Again, it's a patient choice. You shouldn't sell it, but it's important to counsel the patient beforehand that you'll have partial pain relief only. Because especially ladies still expect to fit into narrow shoes, and that's not possible with all insoles. Now, this is lateral impingement. It could be in the Gissane angle, an example of bone edema in the Gissane angle from impingement, or it can be calcaneal fibula. Again, very difficult to correct completely with insoles. Now, the last bit is this is the pre-reduction. So you can see the heel is in valgus, and when you correct it, the fixed supination comes. So you've got to account for that with the insole as well, and make this part take weight. Otherwise, you can, in some patients, have lateral pain with insoles because all the weight will be transmitted laterally. So this is before correction. This is after when the heel is corrected. Hope that makes sense. The other common mistake is just doing exercises like this to stretch the Achilles, when actually all that's happening is it's causing subtalar dorsiflexion. So it's important to do stretches with the foot in inversion. So you might not realize that, but when you stop dorsiflexing at the ankle, it's like links in a chain. The next link is the subtalar joint, which can evert and dorsiflex. And that does not stretch the Achilles. It just causes more flattening of the arch. So to prevent that happening, you either do the exercises with the insole in place to prevent the heel from tilting out, or you can buy stands like these to do the stretches. Needless to say, weight loss really important. Counsel the patient. If you don't stress enough, then they don't lose weight. So going on to another common problem. We finished flat feet, going on to metatarsalgia. You have two types, metatarsalgia with no fixed deformity of toes and metatarsalgia with severe fixed deformities. So here's an example of a metatarsal bar and another one of a metatarsal mount. So these offload the metatarsal heads and take the pressure more proximally. A mount will also open up the intermetatarsal space. So it helps with flexible claw toes, Morton's neuroma, Freiberg's, fat pad atrophy when there's more pressure through the metatarsals, and when there is a reversal of the transverse metatarsal arch. An example of when there is a fixed deformity causing metatarsalgia, you can see the severe clawing of the toe. So this is going to cause a plunger-like effect on the second metatarsal head. You can see there. And the fat pad, of course, has been pulled away, so it's a double insult, and there's a lot of pain that's going to happen under the metatarsal head. So this is the reversal of the metatarsal arch with the second metatarsal head prominent. What do? You offload it by providing a gap in the insole. You can call it an offloader or a sink, and it allows decompressing the area. So that's an example of how the insole looks from below. The talk on diabetes is already over, so I won't talk much about it, but a total contact cast helps distribute the weight better and takes it away from the pressure points and helps wound healing, and of course prevents ulcer from happening in the first place. So it's done by taking a mold and then creating an insole, and these fit into shoes with these high toe boxes to accommodate the insole. Again, the simple principle is to get the pressure to reduce. Going to the next common problem, cavus feet. We talked about it. It's like a sports suspension in a car. It's a stiff foot. So you can't always find it totally correctable. What are the problems? The Achilles is tight. And as you know, if you don't dorsiflex, the wide portion of the talus doesn't engage in the ankle. So the ankle, it exacerbates the instability. And of course, it causes more forefoot overload. We talked about the double hinge earlier. And the varus of the heel in cavus also causes the ankle to give way frequently, a common problem. The high arch makes the pressure in the front and back higher. The metatarsals take more load because that's not participating in the weight-bearing area, the arch. And you do have severe metatarsalgia if there's severe clawing. We talked about it in the previous slide, toe deformities and metatarsalgia. So what do we do about it? For the tight Achilles, again, a heel lift. If you have a varus, if it's flexible, you can put a lateral posting. If it is fixed, then you have to accommodate it in shoes and also have accommodative insoles. So it's soft insoles which don't tilt anyway, but just provide cushioning for a foot which has no cushioning. The high arch, we talked about it. you have to provide a better surface area for weight bearing. So get that high arch involved in the weight bearing and reduce the pressure in the heel and metatarsals by having a molded insole. And it has to be of medium density or low density, medium density usually. And for the clawed toes and metatarsalgias, we've already covered that. You can use a metatarsal bar or some padding. So we've finished with insoles, a form of orthosis. We're going on to the next, AFOs. These are more restrictive. They're made of thermoplastic polymers, and they control movements in different directions and are usually used in neuromuscular conditions, and like in children or people who've had strokes. Now, you can make modifications on top of a simple plastic device. You can add insoles to it. You can add rocker bottom to it. I'll show you examples of it. Or you can use it to change the direction of the ground reaction force. Again, I'll show an example in the next couple of slides. This is an example of how an AFO is used to accommodate the equinus. You can see the added bit of heel. So, and at the same time, hold the foot in a neutral position in other planes. Now, this is an example of how an AFO can be modified. As you can see on the extreme right, this AFO has an anterior band in front of the tibia. So in patients with conditions like cerebral palsy, the knee tends to collapse or keep flexing in the stance phase when it ought to be extended. So the ground reaction force from the foot actually makes it worse. So it's going behind the knee when it ought to be in front in the stance phase. So what this device does is the ground reaction force at the forefoot in the stance phase pushes the whole splint back. As you can imagine, it rotates, and the anterior bar pushes on the tibia and extends the knee and brings, you can see the ground reaction force now is in front of the knee. So you can make the patient relatively more stable. Obviously, it's possible before any fixed deformity develops. So it works well in the early stages. Hope that is clear. This is called a ground reaction AFO or a flow reaction AFO. Now going on to shoes, these are different parts of the shoe. It might seem obvious, but these are areas where we make modifications. The toe box, you can make modifications to the heel or the heel counter. You can make that wide to accommodate swelling. This is called the tongue, the whole shoe. This is called the upper. And invariably, you need a high toe box to accommodate insoles. And you've got to want patients that they got to buy new sets of shoes. Now, how can you make modifications in the shoe itself? You can add flares. A common problem is inversion tendencies with a varus ankle. So you have a flare on the lateral side, both in the forefoot and in the hind foot. How does that work? This is a normal heel, and you can see the ground reaction force when you are trying to fall over and invert the heel is a corrective force, the ground reaction force. Now it has a small lever arm there. Now when you add a flare, there's a large lever arm, so it's more effective. So that's how a flare tries to prevent in a fixed deformity. This is a salvage option. In a fixed varus, you can prevent giving way by having a flare. Hope that makes sense. You can add rocker soles to shift the weight bearing area, like during toe off. If you have pain there, you can have the rocker here. And similarly, a rocker in the middle can be good if you have stiff joints, especially a stiff ankle after a fusion. This can be an odd surprise in exams where calipers are provided. You've got to understand how a Tstrap works. So this is a Tstrap on the outside, lateral side. So the vertical component pulls the heel out, and then the horizontal component ties it down. So that's how a Tstrap works from varus to neutral. Obviously, again, salvage options for heavy patients, neurological conditions, and where the heel cannot be corrected fully, but partially, and that they are unstable on their feet and for some reason not suitable for surgery. This summary chart is busy, but you can read it at leisure. It's going to be on the BOFAS site. This from the American Orthopaedic Foot and Ankle Society. The only thing I didn't cover is the stiff big toe. You put a fabricated stiff insert to prevent dorsiflexion and prevent impingement pain. So why do we fail? Why is it sometimes that we don't get it all right? Patients are unhappy. Now, severe deformities don't correct fully. So a simple orthosis cannot overcome the abnormal ground reaction forces and huge body weights. Sometimes patients are not told that they need a new pair of shoes and it doesn't fit into their favorite shoes. So they are unhappy because it's taking up space in tight fitting shoes. So it's important to counsel the patient. Inappropriate prescription. So a corrective prescription for a arthritic stiff foot when it should be accommodative. Unrealistic patient expectations. We talked about it, counseling. Now it is just one little cogwheel. There are others which all need to work together to make the patient happy. Physio, injections, weight loss. Otherwise you will fail. Now, inadequate information to the orthotist is also a common problem because they are in another building elsewhere. So you've got to call the orthotist in difficult cases, explain what's expected of insoles. And also, if the patient cannot have surgery, why? And then the orthotist knows what to do. Sometimes you have a bag full of insoles because there's been no communication between the surgeon and the orthotist. Summary in terms of orthosis, good orthotic management can reduce the need for surgery. Clinical examination is the key to check where the pressure points are. Think biomechanics, hip malalignment, knee malalignment can translate to the foot and the toes. Think out-toeing gait causing hallux valgus. The evidence for the ideal insole for flat feet, etc., remains, something to explore and do research on. Now, just a couple of slides on prosthesis. This is the final bit. What is it by definition? It's a device or artificial substitute to replace the function or appearance of a body part. It's different from the implants, which are endoprosthesis. These are exoprosthesis. Now, we tend to do the amputation and refer the patient to the rehab centers. So we don't actually get involved too much. So where we do get involved is in the patient journey here. Going backwards, the pre-op planning is really important. You've got to speak to family members so they know what to expect. And refer to a pain clinic, especially if you're doing an amputation for CRPS. And of course, the rehab center before the amputation so they know what to expect. In terms of the phases that the patient goes through, you have a pre-amputation phase, post-amputation phase, prosthetic rehabilitation phase, and maintenance rehabilitation phase. In the pre-amputation phase, pain management, building up upper body strength, weight loss, psychological preparation, occupational therapists going to their house and checking things out, all these are important. On the day of surgery, the main thing is pain control. In fact, admit them earlier. If possible, give them a nerve block the night before and keep them long enough so the pain is controlled before they get discharged. After amputation, you've got to counsel them about stump swelling being controlled with special bandages and socks, desensitizing the scar. And in the early phases of rehabilitation, it's mostly trying out the fitting. It may take months before they take the first step with the prosthesis. And in the long term, there could be a late psychological breakdown because it's more than what they expected. Sometimes they end up in a wheelchair. Maybe that's for the best. But these are things you have to counsel the patient about. There could be pressure sores, there could be bone overgrowth. So it's mostly this part rather than knowledge about prosthesis that is important for foot and ankle surgeons. So this is a very brief summary of what we will see normally in an exam situation. So a BK prosthesis, so what are the components of it? You have a socket. It can be either patellar tendon bearing or a total contact. It has a silicone lining. This part is called the pilon. And then you have the foot prosthesis, or which can be of various types. The common one is the Satch foot. You have a picture there, solid ankle cushion heel. It's very cheap, used in quite frequently in all countries because it's durable. You have a soft portion in the heel to provide cushioning. The modern ones have multi-axial joints inside, or this keel, if it's flexible, then you have a dynamic response foot. And of course, you've seen all the athletes wearing carbon fiber ones, which actually store energy and release it. The suspension bit can have belts or a suction cup, or you have a roll-on silicon sock, which has a metal tab at the end, which links to the prosthesis. This is a picture of a science prosthesis with a little window to accommodate the broad end of the stump. And you can see it's patella tendon bearing. The future is robotics with special sensors, so they adapt the flexibility depending on the surface and speed, and have hydraulic mechanisms in the pylon. That's it. Thank you very much. Questions?
Thanks very much, Hari. That was one of the most comprehensive talks on orthotics I've ever seen. Some brilliant concepts that I've not encountered before. I love the idea of thinking of the heel like the rudder of the foot. I think that's very clever and explains quite a lot. We've got a couple of questions here. I might start with one from Katrina Doyle because it goes right back to clinical examination. She's asking, can you explain the difference between the low and the high tiptoe raise and how you do that and what it means?
Basically, it's quite simple. It's exactly as it sounds. So you can try it yourself. So all you need to do is just go into tiptoe mode. And until you go like a ballerina, you don't feel that you're making any effort. So the gastrus soleus can do a tiptoe for a person with a completely ruptured tibialis posterior too. So don't forget, there are other plantar flexors. You have the toe flexors, which are plantar flexors. The peronei go behind the ankle. All of them can give power enough to get the heel off. But only when you tell the patient, go high, and they consciously try to do that, that's when you find that they can or cannot do it. And if they can do it, that's a good sign, which means it's going to curl inwards, partially or fully the heel. And then that gives hope for orthotics to help. If on the other hand, they're unable to do it, then there's a poor prognostic sign that they may or may not be satisfied with orthotics, because the tip post is not going to, you're not going to help the tip post function, which means the arch will remain collapsed, heavy body weight going through the medial arch. So they have pain even with orthosis over the medial arch. So it's rubbing on it. So it's like a completely collapsed structure. I hope I've answered that question.
Okay, next question is from Waleed. He says, as regards the GRAFO, I assume that refers to the ground reaction AFO, is it meant to be in plantar flexion? And can you comment on how that works?
It's a very good question. As I showed in the example, it's for cerebral palsy patients, and it's not for everybody. So you got to first, in terms of whether it's in plantar flexion or not, depends on how much is the spasm component and how much of the contracture component. So in a way, if you had a fixed contracture and it was severe, more than say 10 degrees, it's not really going to work. And so basically the front end is pushed up and that tilts the AFO. So the top end with the band pushes the knee back. So in terms of whether it's meant to be in plantar flexion, yes, if that person has a slight equinus, you put it into plantar flexion. But it's meant to be in neutral. There's always a battle. Sometimes they don't tolerate it, so the orthotist puts it into slight plantar flexion. And also, there are different types. Some have little hinges, spring-loaded hinges, which allow better kind of accommodation of the spasm. And spasm is very variable and sometimes can be there and sometimes not there. So in answer to your question, it depends on the cerebral palsy patient, how much spasm, how much contracture there is.
Okay. Hari, when you fill out your orthotics referral form, do you prescribe exactly what you want, or do you give the orthotist your diagnosis and let them use their judgment and experience?
It's a combination of both. we have podiatrists in clinic, and orthotists can come by anytime I want. I request them. And so for the standard insoles, yes, I say exactly what I want. And I'm sure they modify it too. They are experts in their own field. And on the other hand, for a complex foot, like we talked about the GRAFO and something like that, then I would take their opinion. They are far, far more experienced, simply because I see them once in 6 months. They probably see them 6 times in 6 months to make adjustments. So yes, it depends on the condition.
Okay. So the next comment is from Paul Charlton, who I suspect may be an orthotist. Please correct me if I'm wrong. He says, thank you for your presentation. There are degrees of orthotic intervention, and as with surgery, minimal intervention is best. It's good for orthotists to know any surgical plan, but then good to allow the orthotist to use their experience and knowledge to create the detailed prescription. So I think that's probably what I was getting at there. Some orthotists don't like being told what to do, and they would like to use their own expertise.
No, absolutely. I mean, there's no doubt. Knowledge is vast. I learn every day from orthotists, physiotherapists, registrars. Everyone has their own skills and knowledge. So yes, absolutely. And surgery, especially now with the new consent procedures, November 2020, you got to be very clear that surgery is the last resort, and the zero risk option obviously is orthotics, and you should exhaust all options before going for surgery. That's no doubt about it.
Okay. Another question from Matthew Bose, who says, is there a, you might have to explain this terminology for us, is there a role for a Ritchie brace with intrinsic orthotic and a Kirby skive device for medial deviated talus in the adult flat foot prior to surgery?
Yeah, now you've got to remember, I have this ongoing discussion with my own podiatrist. Now, the average person and an average adult doesn't want anything in their shoes, leave alone something like a Ritchie brace. So if you give them the option of a Ritchie brace, for those who don't know, it's basically something with a molded insole. It's hugging, it's an AFO-like device, very light, very effective for something like, say, a peel-on injury, maybe high risk of infection, trying to go back in. So this is a salvage option, and so it works very well. And in flat feet, again, if there is a person who for some reason doesn't want surgery, or just wants orthotics as a default position, and is high-risk patient maybe, or is a low-activity patient. So yes, that is a role for the Ritchie brace, and there are probably 100 different devices to control flat feet. Finally, it's a patient's decision whether they want to keep trying, or have surgery, which of course has the risk of making things worse, a small but definite risk. So I hope I've answered that question. So in real life, I wouldn't go on and on trying insoles in the average patient with flat feet who has failed with the simple insoles. So I wouldn't go on to more restrictive devices, simply because, not that I make the decision, the patient wouldn't want it. I would, as an individual, can be empathetic to that concern. Yeah.
Okay. I'll ask you a practical question, if I may. A high-risk patient turns up to your new patient clinic with that plastic bag full of 30 years worth of orthotics, and they are demanding an operation. Where do you go from there? Where do you start?
I work in a tertiary referral center, so it's an everyday practice for me. So we have a protocol. Firstly, it's about counseling. The first, there'll be a 3-page letter as to ABC options and the risk factors. I put a percentage for surgery, so maybe like instead of 90% success rate, 80%, and then 3-4% chance of getting worse, and so on. So first is an MDT. First, obviously, you can't do it the first time they come because it's unexpected. So you write a detailed letter, pros and cons, and why it's high risk, and then copy it to the patient, give the leaflets, and then get them to an MDT. And in an MDT, you have the podiatrist and the orthotist, and not the orthotist, the other consultants are there, 2 others. And we say, again, surgery is on. We never deny surgery unless it's a life and death matter. And we give a certain percentage. And if they still want to go ahead with it, we read them the kind of riot act saying you may end up with an amputation. And I would say 9 out of 10 times they agree with us and they are reasonable. They try and see if there is an option out, meaning if the podiatrist in that meeting says, okay, let's try this, something new, then they try that. If on the other hand, everyone agrees there's nothing else, the bag of insoles is it, then they tend to go for surgery with a higher risk of failure than a normal individual.
Okay. So there's a question from Olga Jones, who is looking to the future. She says, do you really see a future in orthotics, given that the footwear culture is changing drastically? Things such as fit flops, MTBs, the footwear market is becoming so diverse and accommodating that some of these patients or clients may be able to use those instead of specific custom orthoses.
I actually, in my GP slides, I have brand names of shoes which I recommend, but because I was told we should not align ourselves with any company, I've removed those slides. It's actually a boon. I agree with you. All these MBT shoes and memory foam lining, various types of softening of the sole through air pockets. Patients love it because you have a choice, because the custom-made shoes are ugly. There's no doubt about it. So yes, there is a role. Obviously, the younger you are, the more likely you'll try something off the shelf. And that's why the orthopedic surgeon should have knowledge of what's on the, what's in the shoe store as well as in the orthotics department. But there will be a small role for the severe deformities, obviously. And for the active young individual, I'll always say it's better to get something off the shelf. Okay,
there's one more question, and we might have time for a case discussion, if possible. Catherine Parkinson is asking if you have orthotist as part of your MDT.
Yes and no. So basically, it's all to do with NHS money, of course. To have someone come and spend, don't forget that it's a whole afternoon. So you have to find the salary, whereas these podiatrists are in the clinic anyway. So if needed, yes, they come in and that is like spend time for 20 minutes or 15 minutes for one patient, but it's not scheduled. So you have to tell them in advance. And yes, it happens less often in our clinic, but if you had the money, that's perfect.
Okay. Are you happy to do one of your case presentations? We've got a few minutes left.
I've got, yeah, definitely. Quickly to answer the question there about you cannot use insoles indoors. That's where somebody's already answered that question. Off-the-shelf shoes, lots of them are there, slippers with modifications. And again, I don't want to tell brand names.
Right, thanks, Hari. Two very interesting cases there. The questions seem to have dried up. Unless anybody else on the panel has anything to ask. I'll give you a couple of seconds just to respond and unmute.
Great lecture, thank you.
Okay.
Thank you. Thank you.
Well, Hari, I think we've all learned a huge amount tonight, even those of us who have got a few years behind us. Every opportunity like this is a learning one. So thank you very much indeed for your time. And thank you everyone for your contribution, for your questions. It's nice to see the whole multidisciplinary group attending these lectures and answering questions for us. Don't forget, please, to provide your feedback, and then you will get your certificate and CPD points. And on that note, I will wish you a very pleasant evening. Thank you very much indeed.
Thank you, everyone. Bye-bye.